Hello and welcome back to Ice Rounds. I'm Dave Young, the same guy for the last few lectures. I'm one of the Wilderness Fellows at the University of Colorado, if I haven't met you yet. I have my email right over there, daveyoung222@gmail.com. I'm a little under the weather right now, so I figure I don't need to be on the camera so much, but I can just do the PowerPoint as full screen. So I apologize for my nasally voice more so than usual. Why don't we get started? I was hoping to talk about Frostbite today. This should work. Okay, there we go. So I was hoping to talk about Frostbite today. I felt it was a little more pertinent to your treatment down there in Antarctica, and I thought it might be a little bit more interesting. I do know that some of you may have had this lecture before. It looks like Dr. Lemery gave a lecture on frostbite a number of months ago, but I figured it was worthwhile reviewing. And then maybe there's some new stuff in here too. So I'm going to go ahead and get started. There's a decent amount of stuff today, so we're going to move pretty quick. There's a case. We're going to go over some non-freezing cold injuries, frost nip, chilblains, and trenchfoot. Then move on to the meat of the whole discussion, which is about frostbite. We'll talk about the pathophysiology, the classification of it, as well as some treatment, and we'll summarize and maybe watch a video at the end if you guys have time. So the case, we have a 49-year-old gentleman who has no past medical history. He's a climber and has done a decent amount of climbing before. He's climbing at extreme high altitude this time. He developed photokeratitis, which is snow blindness, and can't continue on the summit day. So he's quite high in the mountain. He is told to descend with the aid of a guide as other members of the team continue towards the summit. Unfortunately, a blizzard comes in and the patient gets separated from the guide. He is lost in the mountain overnight. He did an emergency bivvy and made it to a lower camp the next day. That camp has minimal medical supplies and has a medical professional down in that camp. So imagine yourself as that medical professional at that camp and what you would do for this man. When you first see him, appears to have severe frostbite and is hypothermic. He is mentating but cannot ambulate any longer on his own. He kind of collapses in the tent, and you are there to help him. So think about, as we go through this discussion and this presentation, what you would do for this man. All right, let's start with the basics and the very easy things. Frost nip is not very interesting. It's just cold induced. You can have some numbness. There's no tissue damage at all. When you warm it up, it does just fine. Here's a couple pictures, some lips and nose that are a little bit frostbit, ears. We have some toes that are even labeled as frost nip. A lot of skiers or people who even just go outside to shovel their driveway may get some frost nip. Not dangerous, and that's about it. Chilblains is a little bit interesting in the fact that it only affects predisposed individuals. It actually does damage the capillary bed when it's exposed to the cold, and there's something about these individuals' normal physiology that causes this. It may actually, if someone's not diagnosed with another disorder, they may actually have an underlying disorder that may need to be diagnosed, such as a connective tissue disorder, as well as an autoimmune disease. It most commonly affects the ears, nose, extremities, the acral areas. After the exposure to the cold, rewarming produces skin discoloration. It can be red to dark blue. The affected area will be painful. It may also be burning or itching, and occasionally with severe cases there can be some blisters. It'll be much different than the blisters we see later with frostbite, but there can be some small clear fluid-filled blisters. The whole disease typically heals within 7 to 14 days. Usually the skin looks a lot better after just a couple days. Here's some examples of just of the feet here. Another picture of the hands. It almost looks like a vasculitis. And lastly, a little bit purple discoloration of the earlobe. Oh, no, not lastly. A little bit of the hand there. There we go. Okay, prevention. So you want to prevent cold exposure, of course, or tight-fitting shoes. Rapid rewarming can actually make the disease a little bit worse. If you suspect frostbite, you'd want to rapidly rewarm, but if the patient has a history of chilblains, you may just want to slowly rewarm them. It can lessen the severity of the disease. You'll want to rewarm in warm water, but afterwards you want to keep them dry. You can apply a topical steroid cream if they're itchy. And there's been some evidence showing nifedipine, which is a dihydropyridine. It's a type of calcium channel blocker that does peripheral vasodilation. So that may actually be able to help these people too. It's a medication that's used in people with Raynaud's disease. So trench foot, it's named so for trench warfare that occurred during World War I. It's also called immersion foot. We don't do much trench warfare anymore, but we may see this disease in urban homeless populations. It occurs because of a non-freezing temperature between the temperatures of 0 to 15 degrees Celsius. Colder temperatures will actually lead to faster damage. So people will maybe even within 24 hours actually have some damage because of the trench foot. In fact, some severe cases have noted some nerve damage within 24 hours. Let's go over this flow chart. We'll start off in the middle on the top with cold and wet exposure. We'll start going to the left with local nerve cooling. So the cold, wet exposure will cool the nerves, and if they're cool for a certain amount of time, it actually can leave some nerve damage, which may lead to sensory impairment. So people may not even really notice that their feet are really uncomfortable or particularly cold. If we head to the right, we'll see that just having a wet foot in some boots for a prolonged period of time can lead to swelling and breakdown of the skin. If we go to cold, wet exposure and head now downwards, we'll see that vasoconstriction happened because of the cold, but also maybe if it is trench warfare, maybe pain or fear can even cause vasoconstriction. This will lead to decreased blood flow. Of course, constrictive footwear can also contribute to this. And if it lasts for quite some time, ischemia can result, which is lack of blood flow and hypoxia to the tissue, leading to endothelial or vascular damage, and can lead to loss of vasodilation. And so we don't have the protective effects to keep rewarming the foot, and the foot can just continually get worse. There's 3 phases. There's a pre-hyperemic phase, hyperemic phase, and a post-hyperemic phase. In the first phase is basically when you first take off that boot, you'll see a yellowish, white, mottled, and cool extremity. The patient typically has some anesthesia, and then muscle cramps are common to find as well. In the hyperemic phase, this is when the patient becomes, it has a lot of pain. It's a throbbing pain that can last after 36 hours, but is usually worse within the first day. The foot will look quite warm, it will feel warm, it'll be erythematous and swollen. You may feel a bounding pulse, but the cap refill is actually quite delayed. Blisters may form, but that's only in severe disease. In the post-hyperemic phase, the foot will go from warm to actually cool again, and a strange phenomenon, hyperhidrosis or very significant amount of sweating will occur in the affected regions. The patient may now just have dull aches, but it's not particularly painful, and if there's enough nerve damage, they may actually have some anesthesia. Severe cases can lead to gangrene, ulcerations, tissue loss, can actually be quite bad. Typically does not get that bad, but we'll see some pictures when it gets not so nice. Here's a quick picture. You may have had a foot kind of that looks like this after maybe cycling in the cold weather, wet weather, maybe rain, and the foot looks very white. It can be a bit mottled. It doesn't look mottled in this picture, but it could be a bit mottled, and this is kind of the starting of a trench foot. That foot may have done fine, but if it doesn't do fine, or if there's a really prolonged exposure like in a trench, then something like this picture may occur where we're seeing a hyperemic phase where the foot is it's a little hard to see, but very red and swollen in this picture. The patient's going to be in quite a significant amount of pain. Here it looks like there's some tissue damage, so maybe the feet were kind of getting a little macerated from the cold, wet conditions. This is quite a severe case. This is actually of an Argentinian miner who was wearing his boots for 46 days. So a significant amount of time before ever taking his boots off. And then when he did take them off, they looked somewhat similar to this. This is a couple days after. And then about 2 weeks after, we can see that even with trench foot, you can have a significant amount of damage. Again, this is an extreme case, but you can see stuff like this. Let's go to the meat of the conversation, frostbite. Never a good day when your finger just pops off. All right, so physiologically, we are tropical beings. We are very good in warm temperatures, being relatively naked, with very little body hair, keeping us warm. We're not so good in the cold. In fact, our neutral environmental temperature is about 28 degrees or 82 degrees Fahrenheit. Historically, you've probably heard frostbite was quite common in army situations. Actually, in 218 BC, about 50% of Hannibal's army died while crossing the Pyrenean Alps. And then 1778, George Washington's army, there were about 10% of people who experienced frostbite. In 1812, when Napoleon was invading Russia, the first documented effective treatment for frostbite, which was rewarming and prevention of and it's kind of obviously obvious, but it noted that freezing again was actually quite particularly bad for frostbite. In 1943, it was first associated with, which was in World War II, it was associated with high altitude, noting that when you're up to 25,000 feet to 35,000 feet, you're actually going to be quite cold up there. But they noticed that gunners of aircraft or men arming the guns, because it was a life-threatening situation, would actually take their gloves off to have better dexterity to shoot their guns and experience frostbite. All right, physiology. So 80% of an extremity's blood volume is actually venous. The other percent is arterial. And our body has a great method of distributing the blood. It can go, normally it's about 200 to 500 milliliters of blood per minute. However, just to the skin, cutaneous blood flow. However, it can increase it actually to 800 milliliters per minute in hot conditions and decrease it all the way down to 2 to 20 milliliters per minute when it's in cold, very cold. Because the nose, ears, hands, and feet have a rich capillary bed, they're actually some of the best tissues at modifying this. So going very high when it's hot and very low when it's cold with the blood flow. The vascular smooth muscle is controlled by alpha and beta receptors. Alpha 1 receptors are predominant, and when they're triggered, the arterioles will it's in the veins as well, but mostly arterioles will squeeze down and increase peripheral vascular resistance, preventing blood flow from going to any extremities. However, beta 2 receptors actually in the veins will actually vasodilate and but vasodilation still is largely a passive process, that if you take away the sympathetic nervous system, vasodilation results. Cold-induced vasodilation is also called the hunting response. When a hand or foot is cold to 15 degrees, so that's actually the tissue itself is 15 degrees Celsius, maximal vasoconstriction occurs. So our body's ability to vasoconstrict is pretty much at its max. However, at 10 degrees, even colder, what happens is that our body realizes that it continually gets colder, and to maintain perfusion to the tissue, to keep it alive and to keep it slightly warm, this vasodilation occurs. Usually lasts for just a bit, 30 seconds or so, and it'll recur every 5 to 10 minutes in cycles. And it's thought to offer protection from cold injury. In fact, people who have a large ability or they're able to cycle the cold-induced vasodilation frequently, they're actually able to stave off things like frostbite. Actually, interesting enough, repeated exposure to cold, the Inuit population, Sami or Nordic fishermen, and I was saying maybe even people in McMurdo, if you've been down there long enough, may have actually acclimatized to the cold and increase your CIVD response, making those cycles occur at better frequency and maybe the vasodilation lasting longer to better protect your extremities. I want to talk about the pathophysiology. I'm going to get a little bit basic scientist here with you guys. Talk about pathophysiology of frostbite. So there's both a direct and indirect cellular injury that happens. Let's go over direct first. This is actually when the actual tissue freezes. You'll have some extracellular ice formation. Even slow freezing, just gradual slow freezing will cause this. And the ice crystals themselves draw water out of the cells, and it will cause cell dehydration and shrinkage, leading to high electrolyte concentration and pH imbalance. I actually think it's a pH decrease, but don't quote me. I know that the pH gets kind of screwy. Proteins will become denatured, cell membranes will become altered, and the cells can die. Thermal shock is a phenomenon that when these freezing temperatures will cause lipid protein complexes to denature, as well as DNA synthesis to be inhibited. Lastly, especially with rapid freezing, intracellular ice formation can occur. Typically, it usually stays quite liquid inside the cells, but if it's quite severe and rapid, intracellular ice formation will occur. This particularly happens when there's, let's say, like liquid nitrogen or even like butane and things get spilled on the skin and evaporates at cold temperature. Can freeze the skin actually quite significantly, and intracellular ice formation can occur. Crystals themselves will actually damage the intercellular structures and can be lethal to the cells. The indirect cellular pathology, or sorry, indirect cellular injury is secondary to progressive microvascular insult. So this is happening when the skin or when the tissue is actually being rewarmed. It's more severe than a direct cellular effect, so more severe than those last four. This will cause quite a significant effect and really cause the severe symptoms we're going to see in just a little bit. Endothelial damage happens 72 hours after the freeze and then the thaw. Endothelium will swell. It'll protrude into the lumen of the vessel itself, and it will kind of die off a bit. Fluid can extravasate, so fluid can get outside of the vessel itself and create blisters and edema after the endothelial is damaged. Thrombosis can occur, so when the endothelium gets damaged, fibrin will deposit amongst it, sometimes depositing so much that venous flow will actually be disrupted. Typically this happens more so in the venous side because the flow of the blood is so much slower. But the flow in the venous system can stop the capillary flow, which can increase the hydrostatic pressure. Typically the arterial pressure will still continue to just a bit to pass through, but that'll increase the pressure, which will contribute to tissue edema and blister formation. Lastly, prostanoids, examples are thromboxanes and arachidonic acid, can cause vasoconstriction and platelet aggregation. Leukocytes, white blood cells, can sludge and everything can slow down. And all of this is found after a thaw. And these inflammatory mediators can cause a leakage of proteins and then additional blister formation. In fact, the blisters from the frostbite itself will actually contain high levels of these prostanoids. Classification. So this is pretty easy, worthwhile to go through. If all you get out of this talk is to understand mild to severe frostbite, great. It's quite easy, and I'm sure you could probably already knew this before the lecture began. But we can see very mild frostbite. We'll see these like little blister, maybe just like little lesions forming on the fingertips, all the way to those terrible kind of spider-looking fingers. Very large bloody bullae across the fingers there. Early on, it actually may be quite difficult to characterize how significant the disease is when somebody comes to you with frostbite. Advanced classification is very similar to classifying burns, so we're going to go 1st through 4th degree. So it's not that advanced, but it's technically more advanced than mild to severe. So 1st degree burn, the patient's going to have some numbness. You may see some erythema. There will be some white, yellowish, firm plaques that we'll notice. You can see here on the knee and these fingertips. Technically, there is tissue damage, so this does differentiate it from frost nip, but patients will heal just fine. 2nd degree, we'll see some superficial skin vesiculation. So these blisters that'll happen, not necessarily big, but blisters will form. You'll see some surrounding erythema and edema. With 3rd degree, the blisters won't be clear like they were before. They'll be like bloody and look much worse, and it's signifying deeper tissue, so deeper tissue damage into the vessels of the dermis. So this is why when it gets deeper, it involves the blood vessels, and it can look a little more like this. When you look at the middle picture, a little red flag should go off in your head that maybe you shouldn't be taking a picture, and maybe you should be working on getting that ring off that finger. Just a thought. 4th degree, this is the worst kind. It's going to be involving the muscle and the bone. Eventually, it'll cause mummification, as in the picture all the way to the right. Patients will have a high risk for sepsis or other systemic disease. These people need medical attention quickly. You can see these large bullae that are forming. Just looks very angry. And the middle picture is actually someone who the bullae haven't formed yet, but this is just after rewarming, and you can see that it's already involving all the way down to the metacarpals there. So a little more classification. I pulled this this grading system from Auerbach's textbook. We might as well go through it. It correlates to first degree through fourth degree. I just wanted to go over the extent of the initial lesion. Actually, it says absence of initial lesion under first degree or grade 1. We were seeing those little white ones, but there's no permanent lesions and there's no sequelae. There's no blisters in this grade. But as we go forward, we'll see that there are clear blisters in grade 2 or grade 3, and then grade 4, also with the hemorrhagic blisters, but will involve much a larger space, and then bone amputation, concern over systemic involvement in sepsis, and those grades 3 through 4 will have functional sequelae. Contributing factors to the frostbite will include temperature and wind chill. Of course, the colder it is, the more likely you are to get frostbite. But try not to think of it as necessarily as how cold it is, but rather how much heat is being lost from the individual. Because air alone is not much of a thermal conductor. It's if there's a great wind, then the convection from the wind itself can drastically increase the heat loss. So think about it in that sense rather than just how cold it is alone. Conduction, of course, like having your feet in snow, even with boots on in snow, the snow is oftentimes colder than the ambient air, so can still pull more heat from your tissue. Obviously, if you're holding on to something cold and metal, it's never a good idea in cold situations. Altitude, ambient temperature drops about 1 degree Celsius every 150 meters gained, so it gets colder as you go up, as you guys know. And then there may also be another component of altitude. Hypoxia, secondary to the low pressure system, may actually lead to hyperviscosity. There's some interesting studies where people looked at the vascular bed under the tongue, and this may also contribute to the disease. Wetness or humidity, just evaporation can occur, and so wet clothes can cool somebody quicker. Altered mental status, this is a large factor, and in fact, alcohol is implicated in about 53% of non-military frostbite, so a significant amount. And I'm assuming this is related to the urban homeless population. Going inside, putting on clothes requires someone to actually realize that they need to do this, and some people who are either intoxicated or maybe have mental illness or be altered because of haste, high altitude cerebral edema, may not be able to make those decisions and seek help for themselves. Smoking, if you need another reason to not smoke, of course, smoking is going to damage your vascular bed, decreases oxygen delivery to the tissues, and it basically causes some vasoconstriction. It's not going to be anything good for either healing or for frostbite prevention. Immobility is a little bit interesting. So if you are up and walking and making heat, you're less likely to develop frostbite. If you have let's say you can't move, you have a fracture and you have to lie down, those are increased reasons for people to develop frostbite. Fatigue also can contribute. So if you're fatigued and you're not moving fast, you're not generating a whole lot of heat, that's a reason. But also it was documented that with some of these wars that retreating armies would actually have increased prevalence of frostbite, and it was documented that people were just much more apathetic. And exhausted and just didn't care so much about being cold, and had a higher increase of frostbite. Comorbidities, so peripheral vascular disease, Raynaud's phenomenon, which is an autoimmune disease where people have vasoconstriction of their extremities, and some strange gene diseases also can predispose you to frostbite. The International Commission for Alpine Rescue developed these very obvious but worthwhile going through self-rescue techniques. So you should seek shelter if you're ever in that situation. Seek shelter from the colder wind. You guys know that stuff. But drink warm fluids. Exchange wet clothing for dry clothing. Ibuprofen, which inhibits arachidonic acid, is something to consider. Taking it's recommended to take 800 milligrams. If you don't have it, you can try aspirin, but ibuprofen is technically recommended. You can attempt rewarming. I'm sure you've all heard that you shouldn't rewarm the tissue until you know for certain that the patient will not refreeze. The refreezing of a previously injured tissue from hypothermia or from frostbite causes compound illness to it and damage. So you just want to attempt rewarming when you know that it's safe to do so. If someone's at altitude, you can give them supplemental oxygen. You don't want to apply direct heat, like put your foot near a fire. People can't really necessarily feel the they can fear it, but they might not necessarily feel the warmth, and they actually could have now burns on top of the actual cold injury. And you don't want to rub affecting areas. Remember, there's those ice crystals in the tissue, and you don't want to damage. You don't want to damage the tissue at all by rubbing them. So these next 3 slides are all about field treatment, and there's like letters like A through like pretty much like Z. So we're going to go through quite a lot here. Try to stick with me. It's not the most interesting part, but I think this is the most pertinent to your practice down in McMurdo. Yeah, let's just go for it. So this is also the most important piece here that I want to impart on you guys, and this is obvious as well. If a patient is hypothermic, they need to be rewarmed and stabilized no matter what. So the hypothermia itself is life-threatening. So people can actually die from hypothermia. You typically don't die from frostbite. You may have sepsis down the road, but in the immediate time frame, you should treat the hypothermia. You'll want to assess the frostbitten area carefully. Of course, you want to make sure not to injure the tissue any further, and you want to remove jewelry and clothing and really look at the whole body to see what might be involved. Of course, you're going to get vital signs and a temperature, as well as a patient history. Don't forget to ask about tetanus immunization. There have been cases of people with frostbite also developing tetanus later, so make sure they are immunized. If let's say there's a fracture and there's frostbite distal to that, you want to make sure that they have good blood flow to that distal extremity. So make sure you splint the fracture in an area that, or in a way that doesn't compromise the distal circulation. Not that you would ever do that anyways, or want to do that. And then the next in the slide after this, we're going to determine whether or not rewarming is appropriate. So again, I was saying that, if someone's hypothermic, they need to be rewarmed, and if they're not hypothermic but they have this frostbite, and you're going to, you're close to a facility like, let's say, McMurdo, and you're 5 minutes away, just bring them to McMurdo. They can start the rewarming there. 5 minutes isn't going to make a big difference with a cold. And however, if you're far away, and the recommendation is if you're greater than 1 to 2 hours farther than definitive care, you're going to want to start to rewarm that extremity as long as it's safe to do so and no one's in danger at the location where you are. To rewarm, what you want to do is you want to put the extremity in a container where it's not touching any of the sides, so it's big enough, and the water should be about body temperature to a little bit warmer, so 99 to 102 degrees Fahrenheit. Typically, the patient doesn't need any opiates or anything, but it can be a little bit painful. So if it's within your protocols to give pain medicines or anxiolysis, by all means go ahead. They should take ibuprofen regardless. You can just give them pills to take on their own and get some ibuprofen in them. What else was there? It's pretty much that. Just make sure you have additional warm water to be available. If you are far enough away and there's no warm water at all, it's still okay to rewarm the extremities. It wouldn't be considered rapid rewarming, like just putting them in like a blanket and keeping them next to their body heat or warming it up on against your own body. It's reasonable again if they're going to be there for quite some time. And again, the water should be maintained at this temperature, so make sure you're able to get more water and circulate it as well. So the convection from the water itself will continue to keep the extremity warm. Last one, I promise. So the pain after rewarming actually indicates typically that the viable tissue is alive, and that's why it's painful. So it's a good sign. It's unfortunate for the patient, but it's a good sign. You're not going to want to towel dry. The next several of these are all about keeping the tissue protected and not rubbing it or bumping it into anything. So dress it appropriately with some gauze. You can, say, like put a little frame around it, so if in case it bumps into something, then it'll be protected, or there's going to be no direct pressure on it. You can take the extremity and raise it above the heart just for to reduce the swelling. And then just the last statement here is that if the patient is frostbitten on their feet, they shouldn't be actually ambulatory afterwards. So once you start rewarming them to prevent any tissue damage to their feet, they should not be walking. Okay, advanced treatment. This is just a little bit above and beyond, but it's good for you guys to know. We talked about the ibuprofen already and the tetanus. Aloe vera is actually a thromboxane inhibitor, so feel free to use aloe vera. There's some small evidence showing that it's effective. TPA, there's actually some pretty good evidence. It is quite limited in small studies, but TPA does work and it does appear to work. So the indications are that the person it's been less than 24 hours after the thaw, and the sooner the better. There's no contraindications to giving the TPA, like a head injury or a bleeding disorder or recent surgery or who knows. So TPA in those situations. IA means intra-arterial is preferred over systemic. You can give systemic TPA, but IA is preferred if that's possible. And if you do give it IA, then you would also want to give heparin IA as well, which is shown to give additional benefit. There's currently no indication for systemic heparinization, even alone without TPA. So heparin only has a role with IA TPA. Some controversial treatments, prophylactic antibiotics haven't been shown to really help. Obviously, if there is an infection, you'd want to cover for staph, strep, and Pseudomonas. Blister care, like I mentioned before, that there's a lot of these prostanoids in the actual blister fluid. Some thoughts are to remove that fluid so those prostanoids aren't floating around. Current recommendations at this point are just to debride clear blisters over joints. Hemorrhagic blisters you can actually just aspirate, so stick it with a needle and aspirate the fluid, but not to actually de-roof those. Hyperbaric oxygen initially showed no real benefit, but there's some recent studies showing that possibly hyperbaric oxygen may have some benefit, so you may be seeing this in the future. And vasodilators, I can try to pronounce these, pentoxifylline, iloprost, and piperavine. I don't know, whatever it is. I don't know what these meds are, but they're apparently vasodilators, and there's small little data here and there showing that they may work. So if you find out in the future that these drugs are recommended, you know why, because they vasodilate. All right, let's go back to the case. The case is actually of Beck Weathers. Some of you may recognize the name. He was featured in the book by John Krakauer, Into Thin Air. He was part of the 1996 Mount Everest disaster. And I used his case. I was just in Nepal and at Everest Base Camp just a few weeks ago, so I figured I would use this example, but just because it's a little bit tricky of what to do for this guy. What ended up happening was that he was rewarmed at the camp. He actually made it from around Camp 4 down to Camp 2 on his own after and stay overnight on the mountain. He was notably hypothermic but not confused, and so the physician who was actually there decided to rewarm him rather than evacuate him. He also was like not able to ambulate, and they didn't really have the manpower to bring him down. So they decided just to warm him up in the tent. They actually had water and a heat source. So they warmed him up and treated him for the frostbite as well as the hypothermia. They were actually able to get a helicopter up to Camp 2. It was the highest helicopter evacuation to that date, and which was a total ideal decision, and great that they were able to get him down that way. He got down to Kathmandu very quickly, and the extent of the frostbite, the extreme environment that he was in, the fact that they had 2 days of blizzard, and they who knows if the weather was going to turn bad again, and to decrease the likelihood of refreezing just to get him off the mountain, and they were able to do so, and he did okay. He ended up having an amputation on his left arm almost up to his elbow, and then all of the fingers of his right hand, some of his toes, and his nose needed to be reconstructed, but he's doing okay. There's actually, so that's the end of the presentation. Thank you for paying attention so far. If you are busy or if you have other things to do, by all means, that's the gist of it. I typically show a presentation at the end of my videos. Here we go. And so if you're interested, this is just like one of the physician who took care of Beck Weathers on Everest. He took care of him, and this is him recalling the events. And it's a TED Talk, so it's okay. It's supposed to be good. So let's go ahead and play this. Again, it's not adding anything
those climbers were up near the summit,
medically relevant, but it might just be interesting.
That you see up there. And I was down here in Camp 3. My expedition was down in Camp 3.
while these guys were up there in the storm. The storm was so fierce that we had to lay fully dressed, fully equipped, laid out on the tent floor to stop the tent from blowing off the mountain. It was the worst winds I've ever seen, and the climbers up on the ridge were that much higher, 2,000 feet higher, and completely exposed to the elements. We were in radio contact with some of them. This is a view taken along the summit ridge. Rob Hall, we heard by radio, was up here at this point in the storm with Doug Hansen, and we heard that Rob was okay, but Doug was too weak to come down. He was exhausted, and Rob was staying with him. We also got some bad news in the storm that Beth Weathers, another climber, had collapsed in the snow and was dead. There was still 18 other climbers that we weren't aware of their condition. They were lost. There was total confusion on the mountain. All the stories were confusing. Most of them were conflicting. We really had no idea what was going on during that storm. We were just hunkered down in our tents at Camp 3. Our two strongest climbers, Todd Burleson and Pete Athens, decided to go up to try to rescue who they could, even though there was a ferocious storm going. They tried to radio a message to Rob Hall, who was a superb climber, stuck sort of with a weak climber up near the summit. I expected them to say to Rob, "Hold on, we're coming." But in fact, what they said was, "Leave Doug and come down yourself. There's no chance of saving him, and just try to save yourself at this point." And Rob got that message, but his answer was, "We're both listening." Todd and Pete got up to the summit ridge up in here, and there was a scene of complete chaos up there, but they did what they could to stabilize the people. I gave them radio advice from Camp 3, and we sent down the climbers that could make it down under their own power. The ones that couldn't, we just sort of decided to leave up at Camp 4. So the climbers were coming down along this route. This is taken from Camp 3, where I was, and they all came by me so I could take a look at them and see what I could do for them, which is really not much, because Camp 3 is a little notch cut in the ice in the middle of a 45-degree angle. You can barely stand outside the tent. It's really cold. It's 24,000 feet. The only supplies I had at that altitude were 2 plastic bags with preloaded syringes of painkiller and steroids. So as the climbers came by me, I sort of assessed whether...
Oh no. Sorry guys. Bad internet connection apparently. Yeah, we'll leave it at that. He ends up kind of treating Beck Weathers. It's a little bit of an interesting story, I guess. I don't know, my internet's so slow right now. But you can see down here, just to look it up, you can just Google TED Talk, and it's free to watch. All right, so I think that is it. I will see you guys on Thursday. Well, I'll talk to you guys on Thursday, and we'll go from there. I'll address any questions that you guys may have. Thank you for watching, and good luck down there. Let's get it stopped.